Right, let's just see if George can join now, which would be great if he can. Great, many of you are coming back on. Let's see if George is around. If he doesn't come on, I'll try and answer as many questions as I can and try and get him on next week. I'm sure he's trying somewhere in the background. Okay, still waiting. Right, one of the questions I've got here, and I'll start until George comes, is how can you improve egg quality besides supplements and diet? This is a really interesting question because I know, we see so many women. Can I add you, please? Right, okay. Let's see what happens now. Connecting. God for that. Let's have a look. George, what isn't it stressful?
No. We've been trying to join. It keeps saying our request wasn't sent, and we came to, but we managed to sort it out. I'm so sorry.
Oh no, don't worry at all. George, we've had so many questions, and I think it would be a great idea if you would come on next week as well, next Wednesday.
Yeah, sure. I'm quite happy to do so.
Yeah, because we won't get through all of these. So I'm going to start. How are you? Have you had a busy day?
Always very busy, Zita. Always very, very busy.
But it's great to see London opening up today, isn't it?
It is. I haven't seen a lot of it. I've been here in the clinic. Hopefully after this.
Yeah, fantastic. Okay, I'm going to start with some of the questions, and people can join. They can ask us questions as well on here. So the first one is, how effective are pessaries, and can you offer an alternative having an FET?
Yeah, pessaries. The problem with vaginal pessaries, or any pessaries for that matter, any medication absorbed on a surface is subject to the vagaries of absorption. It can be very irregular. You can never predict how well it can be absorbed. You can have the same woman come through for a treatment cycle, have very good levels of progesterone. Next time, the same amount of progesterone, pessaries, still, the levels are very low. So that's always a problem. Actually, the Americans prefer the injections because, it delivers it. But, pessaries or gels can be absorbed very well. In fact, what we did here was, I think it was about 3 years ago, we were measuring the levels of progesterone. We found that the actual levels of progesterone in frozen embryo replacement cycle was the game changer. That was simply the game changer. After a cutoff level, a certain level, the results below was abysmal. Very low pregnancy rate, a lot of miscarriages. So whereas above it, all of a sudden you have pregnancy rates of 70%, very few miscarriages. And what we found has been confirmed by studies in Spain, in Denmark. So pessaries can be used because obviously it's much easier to use. And perhaps a good practice would be to measure the levels either the day before or on the very early in the morning on the day of transfer. And if it's not up to that certain level, then you can introduce injections. Or, as Americans would do, they simply use injections.
Yeah, because I know that progesterone testing is very important to the team at the clinic, isn't it? Sort of during a cycle, and then sometimes women embryos are frozen, aren't they, if their progesterone levels are too low or high?
Well, no, it's if the progesterone level during monitoring is too high,
Yeah,
sometimes we freeze the embryos because what progesterone does, there are two different things, by the way. You have the progesterone in frozen embryo transfer cycle, where the levels are, it's a critical stuff, it's a game changer. Then you have progesterone during stimulation. If it's too high, it advances the endometrium so that you may have an embryo on day 5 and the endometrium is day 8, completely out of sync, and therefore they can't implant properly. So there are two different things. If it's about frozen embryo transfer, then the levels of progesterone in the blood is critical, very critical. And if you're going to use the pessaries, it will help to check the levels. And if it's not adequate, I mean, the levels we found was 50. If it's below 50, it really have to up the game. In Spain, they said 30 something, we think 50. The Danish research said 50, so we're sticking to 50. And other that, or you just start with the injection. The injections almost reliably gives us the right levels. There are 2 injections, by the way. You have the Lubion injection, which you give subcutaneously under the skin, and you have the other one, which I don't know about you, but in the bum, long needle, I wouldn't fancy that. But unfortunately, it gives the best levels of progesterone. In America, that's what they use most often.
Yeah. Okay. So what can be done to improve blastocyst quality? I got 3 blastocysts, but all were poor quality.
Well, that's what we've been doing for ages. It's about preparation, isn't it?
Yeah.
It can help. You need to optimize the quality of not just the egg, but the sperm. People always think egg all the time, but it probably could be the sperm. So we like to optimize that. That's why in our clinic at the Zita West Clinic, the preparation takes minimum of 2 months to optimize egg quality, sperm quality, so that we can also optimize the actual quality of the embryos. There are a few things being suggested, and I can give you anecdotally my own experience in them. One of them was melatonin, which was described by a doctor, I think in Japan, that it could improve embryo quality. I remember when I was in Nottingham, this couple, 2 surgeons from London, came to see me in Nottingham. After 4 failed cycles, they either didn't get to blastocyst, or they got to blastocyst. It was very poor quality, and nothing was frozen. And I told them, well, we can try this. They came through for the first time in about 3 years, had about 5 beautiful blastocysts. Put 2 back, there are twins, 3 left. But you see, I told them that maybe they were lucky. As far as they were concerned, it was because they changed and used melatonin, which is simply what you use. You take it at night during stimulation.
Also for jet lag.
It's used for jet lag, but
yeah. It's a powerful antioxidant, isn't it?
Exactly. We're not quite sure how it improves the quality, but you're right, Zita. It's very high in antioxidants, and that's maybe one of the ways in which you can optimize the quality of the blastocyst. So sometimes we use that. My experience, sometimes it seems to help. When it helps, it's like magic. Sometimes it makes no difference at all. So there are a few things we're looking at now. We'll look at DHEA, having a fresh look at DHEA to see whether it can improve things. The results, if you look at literature, there's some people say it doesn't, some people say it does. But for us, we measure the levels of DHEA in the blood, measure your testosterone levels, and we have markers to tell us maybe in this particular woman that might improve their egg quality. Again, sometimes it seems to do, sometimes it doesn't. But just to take it willy-nilly, no, you need to do some tests to see if you can select a group of women that might benefit from it. So
Yeah.
these are little things little tweaks that may improve the embryo quality.
Yeah, but sometimes in younger women, if DHEA converts testosterone is damaging to eggs, isn't it? If it's too high. So would they need to be careful? Would you do this more for women that are older, or not necessarily?
No, actually, what we look at this in our clinic here,
Yeah.
West Clinic, for quite some time. All the consultants have had meetings on it. We looked into it, and you know, it is quite important for response to stimulation. And obviously, you don't want to be extraordinarily high, but you need some amount of it to
Yeah.
optimize equality.
Yeah, yeah. What about growth hormone? That's another question that's on here as well.
Growth hormone, must be about 5 years ago. I spent an entire weekend. I must have read up to 80 papers on it, trying to figure out, does it really help or not? Unfortunately, all the papers I read in the meta-analysis on the Cochrane database, they use different doses, it was difficult to compare, but if you look at all of them, the summary is that it can improve outcome.
Yeah.
So it may not necessarily improve the number of eggs,
Yeah.
but it's just that live birth rate seems to be improved. And why it may be beneficial to egg is that those women who used it, when they came to use their frozen embryos, they still had better results than people who didn't use it. So it must have been something inherited from the egg development.
Yeah.
So people think if you use it to improve the number of eggs, it may not improve the increase number of eggs, but in terms of outcome, it may improve it. And the way I approach these things is that the only outcome that matters to me is live birth. So if I don't have the number of eggs I want, but I have a live birth, then to me it's successful. There's no point having eggs everywhere and not having a baby at the end of it. So for that reason, in selected cases, sometimes we try it.
Okay. Another question here. There's quite a few questions actually on the COVID vaccine, and women are asking, is it safe to have prior to IVF?
I think that is concluded now, well and truly concluded. The Royal College of Obstetricians and Gynecologists, the American Society for Reproductive Medicine, it's clear, we're no more in doubt at all about that. If you offered it, you have it, because it doesn't affect your fertility. It doesn't even, in fact, in America, they did the Pfizer, with the Pfizer vaccine, they looked at 90,000 pregnant women in pregnancy. It has more than the original study done, showed absolutely no problem with it in pregnancy. So you can have it in pregnancy, and also people who are trying to get pregnant, there's no reason why not to have it. However, given the few very rare cases of blood clotting, even the government here is saying if you're under 40, it's preferable to consider the Pfizer vaccine in those young women. So that is the same. So I think they're all very effective, but based on evidence, particularly this massive study done in America, there's no question, it's so unequivocal now that it is safe in pregnancy.
Okay. So another lady's asking here, if I have immune issues, can I still take the vaccine before embryo transfer?
I don't see why not. I don't see why not at all. Immune issues immunology is a huge umbrella of so many things, massive. So reproductive immunology is slightly different from the other immunologies because it pertains specifically to reproduction. Other in terms of embryo transfer, pregnancy rates, or your fertility, or in pregnancy, preeclampsia, all those things. But there are other immune stuff. So even if you have immune issues, the management in reproductive immunology is specific for what we want it to do. So I don't see why one shouldn't have the vaccine and still go ahead with the immune treatment.
Yeah, yeah, okay. Does diet have a huge influence on egg quality over the age of 40? Well, you're asking the right people here, because we really believe in nutrition and supplements, and you know, it's great that you do, George, because I know that women are born with all the eggs they possess, and they're told that day in, day out, and they're genetically determined. But I think lifestyle and the environment in which the egg is growing can be greatly influenced by nutrition and diet and supplements.
100%. I mean, when I am, you know, unapologetic proponent of this, was that, you know, I went to America. I used to go to America to do some research with a group in Chicago. And Caroline Kulam, she died last November. I didn't even know about that. One of the brightest sparks in this business in America. She had a lab, and went to lunch. And the scientific director said there are 4 consultants that worked in that lab. He said, "What is this one doing others are not doing?" And he was the only one who was doing the holistic approach, the nutrition, you know, massive. They go into nutrition like they're obsessed by it. Because he said, stay in the lab, looking at the microscope, looking at eggs, looking at embryos. The embryos from his patients were always much better looking, and therefore pregnancy was much higher. And he was the only one who did this nutrition stuff. At that point, I thought, no, sod the randomized control studies. If somebody can stay in a lab remotely, not knowing where the eggs are coming from, not knowing who is doing anything, and can tell the difference between the eggs and embryos, I'm sold. I thought, no, that is, anybody who says it's not important, I'm sorry, I disagree completely. I think diet, that's why here we prepare couples for at least 2 months, because we really, Zita and I, completely believe that it is very important to do that for eggs and also for sperm as well.
But I always remember sort of when I first met you at a conference, probably about 15 years ago, and you were really interested in what we were doing. And then I remember going back to see you about vitamin D. And when you came to the clinic, you know, you were absolutely determined that everybody would have vitamin D testing before, men and women, before starting IVF, to get it up to a good level. And look, now we hear vitamin D is mentioned absolutely everywhere, isn't it?
It's incredible, because some patients I treated at Care in Nottingham before I started this clinic, some of them came to London, so I could compare. It was incredible. I remember in particular a GP couple from Birmingham who, you know, they were ready to start, they were prepared, took time off. We checked their vitamin D. I told them, look, can we check your vitamin D? He said, come on, George, we're GPs, we're doctors, we're eating the right thing, blah, blah. I said, look, just humor me. Let's do it. Because I told them, Zita has got this little gem under her seat. Let's do it. He came back, it was low. So I told them, no, we have to wait and bring it up to the levels that is regarded as the right levels. They were so angry with me. But I said, no, if you come all the way from Birmingham, my job is quite clear to me, to help you have a baby. That's my job, you know. I'm not going to cut corners to do it. I'm sorry, you know, we need to postpone the treatment until we get this to this level. Came through, sailed through it at December, beautiful embryos, better response, got pregnant. They have 3 children now. And, you know, when you see it firsthand, what the difference can be, then, you know, it's not, this is what you see in the clinic, and that informs the way you approach the treatment.
Yeah, and that's very difficult about IVF, isn't it? Because and medicine, everything's evidence-based, which is really, really important. But sometimes there are things that haven't got the evidence behind them, but makes a difference to certain women in terms of getting pregnant or not getting pregnant.
or the evidence is lagging behind.
Yeah,
Because
absolutely.
when you were saying all this, people were thought, oh no, here we go again. Now the evidence is that it improves outcome.
Yeah.
So the evidence can be lagging behind. So it is sometimes people that look forward, sometimes are criticized because the evidence can be lagging behind. It doesn't mean there's no evidence, just that it is lagging behind. And by the time it catches up, a lot of women would have had treatment that didn't work. And but the outcome measure, Zita, is a live birth. So all that evidence is fine, but the evidence is the baby is born. So if we're having more babies, then I'm sorry, then it's working.
Yeah, it is, absolutely. So advice on high TSH, high FSH, trying for a baby after 40. I mean, so many women coming through the clinic, George, have thyroid issues, don't they?
They do have thyroid issues. I think it was a study in America that pointed out that maybe if you do thyroid function tests, if you're asking, has this lady got a thyroid abnormality in terms of underactive thyroid or overactive thyroid? That's one question. If you ask the question, is her thyroid function affecting her chances of pregnancy? It's almost as if you're doing two different tests, because if you look at the thyroid stimulating hormone TSH, the normal range from maybe 0.3 to about 4.2. So if it's 3.5, it's normal, and that's fine. The woman hasn't got underactive thyroid at all.
But for fertility,
if you're trying to get pregnant, then that's too high.
Yeah.
Because the TSH level seems to be set at a lower level of 2.5. Some people will even say 2. So so it's almost as you do some test, but almost as if it is completely, you're asking different questions completely.
Yeah.
And that nuance, some people still don't agree with it, but that nuance seems to be what can make a difference sometimes.
Yeah, there's another question here asking about if your TSH is high, should you be tested for thyroid antibodies also?
Absolutely. Why not? I think you should be. In fact, if we're looking at, strictly speaking, you really need to do the antithyroid and then the TSH. If it's certainly high, then I think you should be doing antithyroid antibodies. It just makes sense to do that.
And how does the thyroid antibodies impact on a pregnancy if they're high?
Well, it's a very complex area. It will denote, sometimes we wonder whether it's a pointer that there might be some immunological issues affecting the chance of pregnancy. For instance, a significant proportion of women who test positive for antithyroid antibodies also have natural killer cell abnormalities. So the question has been asked, is it a marker, a surrogate marker for an immune problem that may be affecting somebody's chance of pregnancy? The exact mechanism, and it's not as clear as we would like it to be, but I know research is going on this to see if we can elucidate the actual, nearly down to the actual mechanism. There are quite a few suggestions, but I think one of the prevalent one is that it's probably a marker for immune issues that may be affecting your chance of having a successful pregnancy. Maybe that's a marker to maybe do antithyroid and maybe do a few other things to see if there are any other, do anti-nuclear antibodies as well, to see whether there are any other immune issues that might be impacting on your chance of having a successful pregnancy.
This lady as well also has a high FSH, so obviously hormones are out of kilter here. What are your views on FSH?
FSH, I prefer in terms, when we're checking antral follicle count,
Yeah.
I prefer if we're testing for ovarian reserves, I prefer to do an antral follicle count or
Yeah.
do AMH, purely because they're more stable.
Yeah.
You see, if you do FSH and you haven't checked the estradiol levels, you can't really interpret that FSH, because if for any reason the estradiol level is a bit high, it will give a false reading
FSH
that
level,
is low.
yeah.
So you see, we see people who've done FSH, they just done FSH LH. Strictly speaking, is difficult to interpret. It's very difficult to interpret that result. So, if it's high, then maybe you should do AMH as well. Maybe you should do androgen count, so that you can sort of nail it and find out exactly what the situation is.
Yeah. Another question here that leads on to AMH. Is there anything you can do to improve your AMH levels? I mean, a lot of the time it's down to age, isn't it?
It is, age in particular. Sometimes you can see the younger women. When a woman is born, they have all the eggs they will need for their entire lifetime. And they use it as we go along. And when, for instance, I think when the numbers, at birth, you have about 1.5 million small cells that might become eggs. At puberty, when you start having periods, maybe between 300 and 500,000. These are the ones you're going to use for the rest of your life. So, and some people lose them at different rates. So if it goes below a certain threshold, then you begin to see a rise in FSH.
Yeah.
It doesn't mean there are no eggs, there's still a lot of eggs. It's just that if you're stimulating to get them out, it's a bit harder. The numbers you're going to get will be lower. But if you're trying to conceive naturally and you have low AMH, I'm sure people know that it has no bearing with the chance of getting pregnant.
Yeah.
It's purely numbers of eggs you can get when you stimulate the ovaries.
Yeah.
If you ovulate, it doesn't matter how low it is, you can get pregnant.
Yeah, yeah. No, it's a tough one, that one, a really tough one, because it's decisions that women have to make, whether they do cycles, whether they don't do cycles, whether they move on to do egg donation or whatever. Another question here: how long after breastfeeding should I start an IVF cycle? And this is interesting because I often come across women at the clinic, George, who have had their babies later in life with us, and then I see them on the stairs or in the clinic again thinking, gosh, they've only just had the baby and it's about 10 months old. But because of their age, they're desperate to sort of try for a second, aren't they?
Yeah. And there's no medical reason why people shouldn't start another cycle whenever they want. But nature has made it in such a way that if you're breastfeeding, you don't ovulate regularly, purely because as a means of survival. So when you're breastfeeding, you have a baby. Nature doesn't want you to have another one while you're still breastfeeding a baby. So if you look at that, you find that if you go to natural, like in the tribes where there's no contraception, you still find that ages usually 18 to 2 years. That is gap between children,
Yeah.
because they have breastfeeding, therefore not ovulating. So as Zita said, if somebody's a bit older and they want another baby, then delaying it for too long, may not be a good idea, provided, of course, that's what they want to do. I've seen women who stop breastfeeding, had their period, and said to have another cycle.
Yeah. It depends individually on the circumstances, doesn't it? Because some women are more ready than others, and I think that if you're exhausted, you're not sleeping, you're tired, and you're fighting fatigue, it's best to wait a bit if you can. And many of these women are fortunate because they have a frozen embryo transfer. They've already got embryos to transfer, which is good.
And if they do, then the time pressure is not very.
It's not the same. No,
correct.
Absolutely.
Absolutely. It's only if they have to start all over again.
So this is one of the final questions. How important is the clinic and the facilities used for IVF success? Does it make a real impact? I mean, I know, George, I mean, like for us, every step of the way, from the consultation that lays down the framework to the protocol you're on, to the support you get, to the lab, everything's important, isn't it?
Very important. It pays to, inculcate in a clinic. You need to get everybody, the clinicians, everybody in the clinic, to change their mindset. Mm-hmm. When people come and say, I want to have IVF, that winds me up. Please don't tell me that. Tell me you want to have a baby. The aim, the goal of everything a clinic will offer you is to have a baby. And I dare say, have that baby as soon as possible as well. That's another factor, which is maybe another topic for another day. Not just having a baby, but in a timely manner as well. And what that means to the clinic, therefore, in any good clinic, is that the consultants and everybody else will say, okay, people are here to have babies. So everything you're doing is, how can we improve the chances of having a baby in your arms? Therefore, imagine that you can divide it into 3 groups, 2 or 3 areas. What do you do before you start? Then that's where the preparation comes in, the holistic approach, the acupuncture, the nutrition, all those things will come in at that point so that you're presented with the best possible egg and sperm for the treatment. Then how do you actually engage in the actual treatment itself? Then you have to consider the protocol you're using, try and personalize it. Everybody's, we're not all the same.
Yeah.
One size doesn't fit all. So you have to personalize it, find out for this particular woman, what is the best approach to help us achieve a baby, not just to have IVF, to achieve a baby. Therefore, little things need to be tweaked for that particular lady so that, you can help them to achieve the goal. Having IVF is not the goal, please. The goal is having a baby.
But also, George, it's interesting as well, isn't it?
And after that as well,
yeah,
how do you support after the egg collection? So you have to look at luteal support. It's a big area now where you need to optimize, depending on the protocol. Sometimes things can change. The way you approach luteal support can change depending on what protocol you use. How did you trigger the ovulation? Little things like that. These are things that we're looking at constantly in this clinic, trying to fine tune to see whether we can push it to optimize the chances. And of course, the lab is very, very important. Again, that in the lab, the people have to believe aim is having a baby, not just to have IVF or create embryos. No, baby is the aim. So everything the lab is doing will be, how can we help this couple to achieve the dream of a baby? That's so any clinic that has that as a goal, it informs the entire approach to treatment. And that's why some well doing the same thing, IVF is IVF, but look at the difference in pregnancy rates, massive difference in pregnancy rates. And that's because of the ethos in particular clinics. And also, you have to do what needs to be done to achieve a live birth. Yeah. That is what matters. That's what patients come for. Not, I'm pushing it further, and I keep saying that that's something I'm going to develop in the next, as time goes on. It's not just enough to have that baby. It's also enough. It's also, you have to have it in a timely manner. It makes the clinic work harder. You need to do a lot more before the treatment because you want them to get to the live birth quicker. If you can have a baby in January, why do you want to postpone it and have it in December? So it's not just having a baby, but having it at the right time as well. In my view, right time is as soon as possible.
Because George, it's interesting. Women do come along and they've read so much now and they have in their mind a protocol they want, be it a mild, moderate, light, natural cycles. But it's got to be appropriate to them, hasn't it? In an individualized way.
That's the word, operative word there, Zita, is appropriate.
Yeah.
It's more about appropriate protocol. All the names given to protocols I went to a meeting. Somebody said, "Oh, everybody should have start stimulation with mild protocol 150 units." I said, "Hang on a second. What makes you think it's appropriate?" Some women will overstimulate 150 units. Some people have vaginal hyperstimulation with that. So what's normal about that? What is mild about that? It's about personalizing it and using appropriate, usually I use the right word there, appropriate stimulation rather than picking up words, mild, light, whatever.
Yeah.
It's about appropriate.
Yeah, no, absolutely. George, we've come to the end of our session, and
Have we already?
Yeah, we have. I'd love you to come back on next Wednesday, and go through some of the other questions as well. Are you happy to do that?
Absolutely happy. My patients and their needs are my goal. That's what I live for. I want to help them as much as possible.
Fantastic, George. And you help so many people. So we'll see you next Wednesday, and I will post this on IGTV.